seeing? So are we seeing something radically different? No, because when you peel back the 1,000 flowers that are supposed to bloom in payment reform, you end up actually with a relatively parsimonious set of options. And then you can have a whole bunch of flavors within those options. And sometimes those flavors end up by being more distracting than anything else. And you can, and I think the Healthcare Payment and Learning Action Network that was set up as part of the ACA to categorize alternative payment models has done a good job in at least creating some consistency in how you ought to think about alternative payment models and the different types. And at the far edge of those alternative payment models are what are called population-based models. And population-based models are designed to help provide organizations focused on the health of a population. And they're expressed in payment as combinations of global payments. And there can be different flavors in global payments. And so the direct contracting model is one of the more penultimate expressions of that global payment, because it truly is a per beneficiary per month payment to a healthcare organization. And that should cover the majority, not the totality, but close to the totality of all the care for an individual plan member. And this is actually a relatively big departure from all of the models that CMMI, the Center for Medicare and Medicaid Innovation, has released to date, because all of the prior models, including the Next Gen ACO and the Medicare Shared Savings, and even the Medicare Bundle Payment Program, all still rely on underlying fee-for-service payments. And this is the first time where Medicare has said, look, yes, underlying the transactions, we're still going to require provider organization to submit claims, because asking them to stop a known process for a segment of their patients doesn't make sense. They'll mess it up. We'll all mess it up. So we're still going to rely on that stream of data for information purposes, but not for payment purposes. And that's really the important part. So instead, we are going to give a direct contracting entity, and the direct contracting entity can come in different shapes and forms. We will give that direct contracting entity a monthly per beneficiary payment that will cover an estimated portion of the costs for that beneficiary that is designed to be given by the providers that are part of that direct contracting entity's network. So it is up to that direct contracting entity to contract directly, hence the term direct contract. Direct contracting entity to contract directly with physicians, starting with a primary care group. So there's a recognition that at the core, you need primary care, extending out to specialty care facilities and others. And those direct contracts between the DCE, that's the acronym for the direct contracting entity, and the providers in that mini network can take any shape or form that the two organizations agree the payment ought to be in. So for example, you can create a fixed per member per month for the primary care group. You can create fixed price episode contracts with specialty practices to manage the cardiology, for example, the cardiac care of beneficiaries. So there's lots of innovation that you can do within the DCE, much like in Medicare Advantage. Medicare Advantage plans have the freedom to do lots of payment innovation with the providers in their network. So this is taking Medicare Advantage, for all intents and purposes, into Medicare fee-for-service, and not requiring necessarily health plans to be the manager of those funds, but allowing for provider organizations to take on that responsibility. However, with that responsibility comes significant risk. And to a certain extent, it is more risk than what happens in the Medicare Shared Savings Program, because you are paid upfront a per beneficiary per month payment. And if during the course of a month, as a healthcare entity, the direct contracting entity, you end up by spending a lot more on beneficiaries than what you have been given, you need to float that difference. It's not as if you're going to make it up in fee-for-service payments, because you're not going to get any fee-for-service payments. So it's a different ballgame. And I do think that from that perspective, moving to what are called Category 4 payment models by the Healthcare Payment and Learning Action Network creates a very different type of payment model than what we've seen to date. And if done right, and this is the $1 billion or $1 trillion question, Peter, because these models live or die based on how well they're implemented. And so depending on how well it's implemented, we'll be able to gauge the relative success of the program.